You know, if you break your arm, an X-ray gives you this nice, jagged white line.
Right, it's very clear cut.
Yeah, it's totally binary, broken or not broken. The doctor points at the film, you get a cast, and everyone understands exactly what went wrong. There is a comforting precision to it.
Absolutely.
But when you step into the world of sexual health, and specifically, female sexual response and vulvar pain, that X-ray machine just suddenly goes dark. We are looking at a diagnostic landscape that is incredibly murky.
It really is, yeah.
For so many listeners out there, sexual dysfunction or a sudden, terrifying loss of physical sensation, it just gets written off as stress. It gets blamed on relationship issues or just the natural aging process.
Or they just tell you to relax.
Exactly. It gets slapped with a psychological label, essentially telling patients that the problem is all in their heads. But today, we are taking a radically different approach. We are shining a very bright, strictly scientific light into those muddy waters. Welcome to today's deep dive.
Thanks for having me. And, the medical community is finally starting to undergo this massive reevaluation of how we actually look at sexual response.
It's about time.
Right. We are moving away from those outdated psychological assumptions and focusing heavily on the actual physical hardware.
And the sources we have today are fantastic. We're looking at medical journals, dermatological research, data from sexual medicine clinics, and patient support networks, like the lichen sclerosus support network.
Yeah, and the data from those networks paints a very clear, highly physical picture of what happens when that hardware malfunctions.
Which sets up our exact mission for this deep dive. We are asking a highly specific question for you today. Does the architectural distortion and scarring caused by a condition called lichen sclerosus physically impair clitoral neurovascular blood flow and physiological orgasmic function?
What's fascinating here is that for decades, women presenting with these exact distressing symptoms, a complete loss of sensation, muted orgasms, incredibly painful sex, they were routinely handed psychological diagnoses.
Just told to go to couples therapy.
Exactly. They were told they needed to just relax. But the clinical data definitively proves this is a strictly anatomical, measurable, and physical issue.
It is entirely physical. But before we can understand how this condition breaks the system, we really need to understand how the system actually works in the first place.
Right. You have to know what's normal first.
Yeah, let's look at the machinery of arousal, starting with the clitoral complex, because what most people visualize when they hear that word is basically just the tip of the iceberg.
It really is. The visible part of the anatomy, the glands, is only about 4 to 7 millimeters long.
Wow, so tiny.
Right, it represents just a fraction of the entire organ. The true clitoral complex is a massive internal structure. It actually extends 9 to 11 centimeters internally.
Okay, let's unpack this. 9 to 11 centimeters. For anyone listening, that is roughly the length of a smartphone or like a small banana, completely hidden inside the pelvis.
Yeah, it forms this large wishbone shape beneath the skin, with these structures called the crura running along the pubic bone on each side.
That completely changes the mental map of the anatomy. It's not just a surface button, it is a massive structural organ. And it's incredibly sensitive, right?
Oh, incredibly. It is densely packed with specialized sensory nerve endings. We're talking about a highly complex sensory array here.
Like what kind of sensors?
Well, for example, the tissue contains Krauss finger corpuscles, which are tuned to sense cold and continuous pressure. Then you have the corpuscles of Pacini.
Pacini.
Okay.
Right.
And they act like tiny seismographs. They detect deep, rapid vibrations. And then the corpuscles of Meissner, which are incredibly sensitive to light touch and changes in texture.
So you have this huge internal wishbone structure, heavily wired with these highly specialized microscopic sensors that can pick up everything from like a light breeze to deep pressure.
Exactly.
So how does the blood flow factor into this? Because arousal isn't just electrical signals, it's vascular.
It is heavily dependent on the internal pudendal artery. When a person becomes aroused, the central nervous system signals for an immediate increase in pelvic blood flow.
Got it.
And this causes the clitoral corpora cavernosa, which is that spongy erectile tissue inside that wishbone structure we just mentioned, to rapidly engorge with blood.
So it swells up.
Right. The diameter and length of the internal tissue actually expands significantly, and that presses those nerve endings closer to the surface.
Now, this sounds like something that should be highly measurable. We aren't just guessing that blood goes there. We can track it, right?
Oh, absolutely. Specialists use a tool called a duplex Doppler ultrasound. Think of it almost like a weather radar, but for blood flow.
A weather radar for blood. I like that.
Yeah, and it allows clinicians to measure the peak systolic velocity, which is the maximum speed of the blood rushing in with every heartbeat,
Okay.
and the end diastolic velocity, which shows how well the tissue is holding on to that blood without it draining back out too quickly.
So, by measuring these speeds before and after sexual stimulation, they can objectively quantify that neurovascular blood flow.
Exactly, it's totally measurable.
So, the clitoris is essentially a massive, highly sensitive hydraulic network hidden under the surface. It relies on a massive rush of blood to expand the tissue, combined with this dense network of electrical nerve signals to function correctly.
That's a perfect summary.
It's a stunningly complex piece of biological engineering, and that brings up a really important statistic for you. Research indicates that roughly 82% of women need some form of clitoral stimulation to reach orgasm.
Right, 82%.
So if that is the biological baseline, what happens when this intricate hydraulic and electrical network is compromised?
Well, because this neurovascular network relies on such delicate, precise mechanisms, any physical disruption to the surrounding architecture can be catastrophic to its function.
You need the blood to flow in, you need the tissue to expand, and you need the nerves to be accessible.
Exactly. If the physical structure around it changes, the entire system collapses.
Which introduces the focus of our deep dive today, vulvar lichen sclerosus, or VLS. Let's get into the disease mechanism. What exactly is this condition doing to the tissue on a microscopic level?
Well, lichen sclerosus is a chronic autoimmune inflammatory skin disease. It primarily affects the genital area, and it is surprisingly common.
How common are we talking?
Current estimates show it affects roughly 1 in 70 vulva owners.
1 in 70. Imagine a crowded subway car or a busy coffee shop. Statistically, someone in that room is dealing with this. That is a huge number for a condition that is so rarely talked about.
It really is.
Break down the autoimmune aspect for us. What is the body actually doing to itself?
The immune system essentially gets confused. It tags its own healthy genital tissue as a threat.
Oh, wow.
Yeah, it involves an infiltrate of activated T cells. They're like the immune system's attack dogs. These T cells release specific chemical messengers called cytokines,
Cytokines, okay.
particularly one called interleukin-4. Think of interleukin-4 as a distress flare. When that flare goes up, it activates fibroblasts in the tissue.
And fibroblasts are the cells that build collagen, right? They provide the structural scaffolding for our skin.
Normally, yes, that's exactly what they do. Fibroblasts build a nice, flexible, elastic lattice of healthy collagen, but under this intense inflammatory attack from the immune system, they go into a chaotic overdrive.
So they just start overproducing.
Worse, they start producing significantly altered abnormal collagen. Instead of a flexible lattice, they lay down dense, rigid, fibrotic scar tissue.
Wow, so the body's own construction workers are responding to a false alarm by pouring thick, rigid concrete over everything instead of building normal skin.
Yes, that's a great analogy. And the damage goes even deeper than the surface scarring. The pathogenesis of lichen sclerosus specifically includes severe vascular damage.
Vascular damage?
Right. The chronic inflammation leads to a measurable physical decrease in the number of capillaries. The tiny blood vessels in the affected tissue just disappear.
Wow. So it is not just putting down bad concrete on the surface, it is literally destroying the plumbing beneath it. It's starving that internal hydraulic network of the blood supply it needs to actually expand and function.
Exactly. And as this fibrotic, poorly vascularized tissue takes over, it causes profound architectural distortion of the entire vulva.
Architectural distortion meaning the shape actually changes.
Yes, the labia minora, the inner lips, they can completely resorb. They just flatten out and disappear into the surrounding tissue.
And it attacks the clitoris directly, which is where the loss of sensation comes in.
The most devastating architectural change for sexual function is what happens to the clitoral prepuce, commonly known as the hood.
The hood, right.
The chronic inflammation causes the hood to scar, thicken, and eventually fuse directly to the clitoral glands beneath it.
Fuse directly to it.
Yes. This condition is known medically as clitoral phimosis. The glands becomes completely buried under a thick wall of rigid scar tissue.
Now, I have to push back here for a second because the prevailing wisdom, and honestly what a lot of routine medical advice suggests, is that this kind of genital atrophy, fusing, and scarring, it's just a side effect of losing estrogen.
That's what people think.
It's framed as something that only happens to women after menopause.
It is an incredibly common and destructive misconception. Lichen sclerosus actually has a bimodal peak. It frequently appears in postmenopausal women, yes, but it also appears in prepubertal girls.
Prepubertal girls, wow.
And crucially, It heavily affects women in their 20s and 30s.
There was an observational study in our data that looked at exactly this, and the numbers are just infuriating.
Yeah, the study tracked 503 premenopausal women with biopsy-confirmed lichen sclerosus. The average age of symptom onset for these women was just 27 years old.
27. At 27, nobody is thinking about severe anatomical fusing, and I imagine doctors aren't looking for it either. How long are these patients waiting for a real diagnosis?
The average age of diagnosis in that group was 32.
Oh my God.
That is a 5-year delay. 66% of these women were initially given an alternate, incorrect diagnosis. Because the primary early symptom of lichen sclerosus is often intense itching, they were overwhelmingly misdiagnosed with recurrent yeast infections.
A 5-year delay. Let's think about what that actually means for you, the listener. Imagine going to a doctor with intense discomfort, being handed an over-the-counter antifungal cream, and being sent on your way.
Right, just told it's a yeast infection
And
again.
you do this for 5 years, feeling like you're going crazy because the creams don't work. Meanwhile, your immune system is actively pouring that bad concrete.
Actively destroying the tissue, yeah.
The clitoris is actively being buried in scar tissue, the capillaries are dying off, and the physical architecture of your body is just disappearing. The psychological toll of that is staggering.
It breeds immense anxiety and alienation. And from a physiological standpoint, those 5 years allow the mechanical blockade to fully set in.
Which brings us to the core of our mission today. We see the mechanism, how LS fuses the tissue and destroys the capillaries. How does this mechanical blockade specifically impair physiological orgasmic function?
We'll walk us through it.
Yeah, walk us through the physical mechanics of why the system stops working.
We have to look at the normal mechanics of stimulation. During arousal, as that massive internal clitoral complex engorges with blood, the clitoral hood is designed to glide smoothly back and forth over the glands.
Okay, so it glides.
This gliding mechanism is crucial. It provides indirect stimulation, which the vast majority of women require for comfort,
Right.
because direct, unbuffered contact with the glands can often be too sharp or hypersensitive.
So the hood acts like a protective, gliding buffer. But when clitoral phimosis sets in, that mobility is completely locked down.
The hood becomes fused to the glands, the gliding is completely gone,
Yeah.
but the anatomical nightmare gets worse.
Worse. How?
The fusing creates a closed microscopic compartment, an entrapment space between the hood and the glands.
Oh,
Yeah, this trapped space allows for the constant buildup of keratin pearls and smegma, which is basically a collection of dead skin cells and natural oils.
so you have dead skin and microscopic debris packed into a tiny space that has been glued shut by scar tissue.
Exactly. It creates an impenetrable sensory barrier. You have the external stimulation happening on the outside and all of those dense Pacini and Meissner nerve endings, the vibration and light touch sensors trapped on the inside.
They're buried.
Yes, buried beneath a thick wall of fibrotic collagen and trapped debris.
Here's where it gets really interesting. It's like trying to use a smartphone touchscreen, but you are wearing thick, heavy winter gloves.
Right.
The hardware inside the phone, the sensory receptors, are in perfect condition. They're sitting there powered on, waiting for input. But the physical barrier of the winter glove is so thick that the electrical signal from your finger just cannot penetrate down to the sensors.
That is an excellent way to visualize the anatomy of clitoral phimosis. The nerve endings themselves haven't vanished. They are physically blocked from receiving the input.
And then you add the blood loss.
Exactly. Combine that thick sensory barrier with the vascular damage we discussed. The autoimmune inflammation destroyed the local capillaries. So the tissue is also starved of the massive blood flow required for that hydraulic engorgement we talked about earlier.
So the system is simultaneously smothered by scar tissue and starved of blood. I mean, it's no wonder the physiological result is a total loss of function.
The clinical data strongly supports this mechanical failure. Research indicates that the physical distance between the clitoral glands and the urethra is already a significant predictor of orgasm difficulty in healthy anatomy.
Okay.
So when you take a glans and bury it under immobile scar tissue, pack the surrounding space with keratin debris, and drastically reduce its capillary blood flow, women experience significantly muted orgasms.
Or nothing at all.
In severe cases of phimosis, they report a complete and total loss of physical sensation.
Man, if you can't feel anything, or if trying to feel something just causes sharp pain because the scarred tissue is micro-tearing under the friction, your brain is instinctively going to shut down any desire for sex.
Of course it is. The resulting low libido is not a psychological failure.
Right.
It is a highly logical, direct consequence of a mechanical and physiological breakdown. The brain is initiating a protective mechanism to avoid interacting with a system that is fundamentally broken and prone to pain.
It is incredibly validating to hear it laid out as a mechanical failure rather than a personal one. But, we can't leave you, the listener, sitting with this heavy information without a path forward.
No, absolutely not. There are solutions.
If the inability to orgasm here is caused by a physical mechanical barrier and localized inflammation, it stands to reason that removing the barrier and stopping the inflammation could restore the function. Let's talk about reversing the damage. Where does a patient even begin?
The absolute first priority is stopping the active disease process. You cannot repair a burning house until you put out the fire.
Right. Stop the damage first.
You have to halt the autoimmune inflammation. The gold standard treatment across dermatological and gynecological fields is the use of ultrapotent topical corticosteroids,
Okay.
most commonly an ointment called clobetasol propionate.
And we need to be clear here for the listener, this isn't just a soothing anti-itch cream. This is fundamentally changing the cellular environment, right?
Exactly. Clobetasol is a heavy-hitting intervention. It penetrates the tissue and acts directly on those rogue T cells and the distress cytokines we talked about.
It shuts down the attack dogs.
It chemically commands the immune system to stand down. By doing so, it stops the ongoing destruction of the capillaries and prevents the fibroblasts from laying down any more of that abnormal fusing scar tissue. Getting the patient into clinical remission where the disease is no longer actively attacking the tissue is step one.
So the steroid ointment turns off the bad construction workers, but it doesn't dissolve the concrete that has already been poured.
Unfortunately, no, it doesn't.
If a patient's clitoris has already glued itself shut, the steroid isn't going to magically unfuse it. For that, we have to talk about the surgical intervention.
Right. For patients with significant clitoral phimosis who have successfully reached clinical remission using the steroids, specialists, often gynecologic oncologists or highly specialized sexual medicine physicians, can perform a procedure called a lysis of adhesions.
Lysis of adhesions, what does that actually look like for the patient? Because honestly, surgery on such a highly sensitive area seems incredibly intimidating.
It sounds scary, but it is a delicate, specialized procedure, often done in office with local anesthesia.
Oh, in office.
Yes. The surgeon makes a tiny, highly strategic incision to physically separate and unglue the fused clitoral hood from the glands. They meticulously clear out any of the trapped keratin pearls and debris, essentially unvarying the clitoral complex and restoring the natural, necessary mobility of the hood.
And what do the outcomes look like? Because if you are going to let a surgeon near that anatomy, you want to know it actually works.
The clinical data is overwhelmingly positive. One major study focusing on patients who reported decreased clitoral sensation prior to the procedure found that 75% of them experienced increased clitoral sensation post-surgery.
75%. That is a massive rate of return for restoring a complex physical function.
It is, and other clinical surveys mirror those results. Data looking at outcomes following in-office lysis procedures found a 64% improvement in the ability to achieve orgasm,
Amazing.
a 63% improvement in general sexual arousal, and a remarkable 76% improvement in pain reduction.
Wow.
Crucially, in these studies, not a single participant reported a worsening of their symptoms after the procedure.
That is genuinely life-changing data. But let's be real, surgery, even a minor in-office one, is daunting. What about the listener who might have mild fusing or who just isn't ready for a scalpel? Are there non-surgical options that actually break down this scar tissue?
Yes, there are highly effective conservative approaches. For cases of partial phimosis, where the hood isn't completely fused shut, clinical data highlights a technique called clitoral myofascial release, or CMFR.
Myofascial release, like what a sports massage therapist does for a tight shoulder or like a knotted calf muscle?
It is the exact same biomechanical principle,
Yeah.
but applied to the vulvar tissue by a specially trained pelvic floor physical therapist.
Okay.
It involves highly specific, targeted mobilization and stretching of the scar tissue. By mechanically manipulating the tissue, the therapist can physically break down the abnormal collagen cross-links over time.
So they literally work it out of the tissue.
Right. The goal is to manually dissolve the adhesions, restoring the mobility of the tissue and preventing it from sticking together further. Clinical reports show cases where CMFR successfully restored normal clitoral sensitivity, gliding motion, and orgasmic function without the patient ever needing surgery.
So what does this all mean? If you take absolutely nothing else away from this deep dive, let it be this. If you or a partner are experiencing a sudden, terrifying loss of sensation, muted orgasms, or unexplained pain during intimacy, it is not a psychological failing.
Absolutely not.
It is not because you aren't trying hard enough, it's not because you're too stressed at work, and it's not just a normal part of getting older. It could very well be a highly treatable, strictly physical architectural issue that is literally blocking blood flow and nerve access.
And if we connect this to the bigger picture, this highlights a massive systemic gap in how routine medical care is delivered. It is absolutely vital for patients to advocate fiercely for their own anatomical health.
You really have to speak up.
If a patient reports low libido or a loss of physical sensation, clinicians must be demanded to look past the standard psychological questionnaires. They must physically, thoroughly examine the clitoral architecture for signs of power, resorption, and phimosis. The underlying mechanical cause must be identified and treated.
Before we wrap up, I want to leave you with one final provocative thought. During our research, we uncovered a fascinating biological quirk called the Koebner phenomenon.
Oh, yes.
Oh.
It is a well-documented dermatological response where physical trauma to the skin actually triggers new lichen sclerosus lesions to form in that exact spot.
So trauma causes more disease.
Exactly. Friction and microtrauma recruit the inflammatory immune cells to the area, kickstarting the whole scarring process.
Now think about the intense, maddening itch-scratch cycle that comes with early lichen sclerosus. Or think about the countless women who force themselves through painful sex, dyspareunia, because they don't know they have a disease, they just think they need to relax and push through it.
Right, just grin and bear it.
Could the microtrauma from that desperate scratching in the middle of the night and the severe friction from painful, unlubricated intercourse actually be triggering the Koebner phenomenon? Could they be accidentally accelerating the very autoimmune disease that is actively erasing their anatomy?
The clinical evidence strongly suggests exactly that. The physical trauma from untreated symptoms directly compounds the disease process. It creates a devastating, accelerating feedback loop of inflammation, microtearing, and denser scarring.
It is a chilling thought. Pushing through the pain might literally be destroying the hardware, but it perfectly highlights exactly why early diagnosis and physical examinations are so incredibly critical. We have to fix the X-ray machine. We have to stop accepting murky when the problem is mechanical. Thank you for joining us on this deep dive. Keep asking the hard questions, keep advocating for your anatomy, and keep seeking the truth.